Excellent. Good afternoon, everybody. Thank you very much, Angela. Thank you very much, CPTR, for inviting me to speak with you today. You'll see from the printed agenda that the topic was originally meant to be TPPs for molecular diagnostics. You'll notice that this title is slightly different. To be perfectly honest, I thought if I gave you a talk about TPPs at this time of day, you would just simply not make it to the next one. And so I thought I'd focus instead on this, which is, it's really the bigger picture behind TPPs. TPPs are just a tool. A target product profile is a tool to get to somewhere. And so I thought I'd rather talk a little bit more about where we're trying to go and have the larger picture of where we're trying to go with targeted next-gen sequencing for rapid diagnostics in tuberculosis. And then I'll have elements of TPP in there in terms of what we're trying to do. First of all, I just want to talk a little bit about something that everybody here is very aware of, so I'll be very quick about it. Why do we need next-gen sequencing for TB diagnostics? It's actually a question that's being asked quite a lot. There's many reasons for it in terms of TB diagnostics and central labs, but the most important and the most compelling for me came out last year in 2016. 2016, the WHO essentially recommended a short-course TB treatment for anybody that had MDR-TB that was not resistant to anything else, any of the other drugs in the regimen. And so straight off the bat, with one endorsement, the WHO essentially made 580,000 people who were estimated to have MDR-TB eligible for short-course TB. So how many of those actually got any diagnostics to determine if they could get short-course TB? 50,000. So we needed 580,000, and we got 50,000. That means all those folks who are eligible for short-course TB, which means 9 months instead of 24 months of treatment, didn't have any way of getting there. Well, they had some ways of getting there, but not enough. And so what we basically are looking at is next-gen sequencing as part of the solution. It's not the solution. It's not a solution that's going to make all other solutions redundant. It's one of the solutions that we are going to need in order to get to where we need to go with second-line drug resistance testing. And that's in combination with phenotypic testing, second-line drug resistance testing with the Hain-LPA, which is the only WHO-endorsed method at this time. And so why do we think that NGS could be part of the solution? The main reason is that it's comprehensive. And so it's something that can help us move towards something that's very similar to the phenotypic drug susceptibility testing we currently have. It's flexible in that it's an open platform, so that's where it's different than other molecular diagnostic testing, something like the Hain-LPA, which is basically design locked when it leaves the factory, and it can't be really turned into anything else unless a complete redesign goes through. Next-gen sequencing has the flexibility to allow us to explore and change things along the way. It's also scalable in terms of throughput. So largely, I think next-gen sequencing, because of price considerations, is going to really be a high-throughput solution for us for next-gen RDST, but it's also scalable. You can put one sample through if you want, or you can put 100 samples through if you want. It's also rapid relative to the solutions that we have now. So relative to phenotypic drug susceptibility testing, it's basically days instead of weeks, or most times months. It's also multi-use. So this one individual set of instruments can do a lot more than just do rapid drug susceptibility testing. It can also do surveillance. You can do treatment monitoring, transmission mapping, as well as many other non-TB uses. So it's a multi-use technology. So what are some of the downsides of it? Downsides of it is next-gen sequencing is expensive. It's expensive relative to options that are available today. It's also rather complicated. Next-gen sequencing as it stands today isn't really an assay. It's not a solution, it's a method. And it's a method that's been used a little differently by everybody in different labs. So, and the other thing about next-gen sequencing is that it's really not a thing, it's multiple things. And two of the biggest categories are the simplest ways to divide ways of looking at next-gen sequencing and how we can look at it in drug susceptibility testing is a whole genome sequencing approach to relative to a targeted next-gen sequencing approach. The whole genome sequencing approach, many strengths in that basically you have a full genome sequenced. You don't need to know anything about it ahead of time. You do your sequencing. All the work comes in the post analysis, where you basically analyze look for mutations that you know are resistant, cause resistance, and go from there. But whole genome sequencing has a lot of weaknesses. It's kind of slow. You can't currently do it directly from sputum, which means that you still need the same culture labs that are available for phenotypic drug susceptibility testing, which means, again, slow. It's also expensive. You need BSL-3 labs, et cetera. And it's complicated bioinformatics. It's a complicated method. And there's lots of reasons why it will become difficult to put whole genome sequencing into low and middle income countries in the short term. In the long term, I have no doubt that that's where we'll go. But in the short term, we need something simpler. Targeted next-gen sequencing, on the other hand, is basically sequencing direct from sputum. It means that you can basically hit up to 200 gene targets right directly out of sputum. It's faster, simpler, less expensive than whole genome sequencing, and a much simpler protocol to establish in low and middle income countries. There are some weaknesses, though. Because it's a targeted-based approach, it means you have to know the targets before you go in, which means you have to have some pre-knowledge of what you're doing. It also has less information than whole genome sequencing, so the transmission mapping isn't nearly as high resolution. But given that we're trying to create a next-gen solution for rapid drug susceptibility testing, that's not something that's going to be put in place 10 years from now or 5 years from now. FIND has basically used most of its resources to try and develop a next-gen sequencing system that can be put in place in the next 2 years. And for that to work, it needs to be a targeted next-gen system. So what we're working towards is a culture-free, end-to-end next-gen solution for reference labs in low and middle-income countries. So this is where we get to the TPP part. Now, a target product profile for next generation sequencing is a long multi-page document that actually many of you in this room have already been a part of helping us develop, and I'm hoping for those of you that have not been a part of it will be a part of it in the next surveys that we'll be putting out around this TPP in terms of what should be in it. But these are some of the main features of what we think that should be in a next generation sequencing platform needs to look like. It needs to work direct from sputum. So in other words, culture-free, no BSL-3 labs. It needs to detect the primary, first, and second-line drug resistances. So that's all the XDR drugs plus pyrazanamide. But it also has to be open platform. You have to be able to expand it to the new mutations, delaminid, bedaquiline, and laser, etc. The cost per sample should be less than $30 for library preparation and sequencing and analysis. So less than $30 per sample. So to give you a comparison, if you want to do second-line phenotypic DST right now, the cost is roughly $50 per sample. So in other words, cheaper than current options in phenotypic testing. Limit of detection is another key element for a next-gen sequencing system, and it should be able to basically detect, in terms of minimal characteristics, about 5,000 MTB genomes. Optimal characteristics is 100 genomes, so it should be able to ultimately work with 100 genomes. In terms of heteroresistance detection, mixed population detection, NGS has a lot of very interesting options and a lot of very interesting opportunities for us to do things that we can't currently do with other methods. And for there, we basically think that a minimal operational characteristic should be about 500 resistant alleles in about 4,500 susceptible alleles. There's about a 1-to-10 ratio of resistance to susceptible alleles we should be able to detect and report on. So this is a generic targeted amplicon NGS workflow. This looks neither simple or cheap or something that you could basically easily put into a low and middle income country. Essentially, there's 5 elements. There's a sample extraction, there's library preparation, batching and pooling, sequencing, and analysis. Now, as it stands there, it's probably way too complicated for us to broadly be able to put this into low and middle income countries. So what we've been working at for the last 2 years with several partners, many of the people in this room actually, is simplifying and automating the workflow, reducing the number of instruments, consumables, and reagents, decreasing costs of all the different steps, and improving reliability, interoperability, and of the component instruments and reagents, all towards something that's going to look a lot more like this. Still has the 5 components for next-gen sequencing, but way, way, way more automated. So we're looking at automated DNA extraction. We're looking at 1- to 2-step library preparation, batching, and pooling, possibly, hopefully, fully automated sequencing, fully automated back-end analysis. So do we actually, if this is a fantasy, or do we actually have something like this already available? And the answer is, based on all of the analysis we've done, multiple landscapes, working with multiple partners, we basically have 2 TB assays that fit the minimum characteristics and roughly fall into these categories. There's a simplified PCR approach, which Dave Engelfeld will probably be talking a bit about later, and there's a more comprehensive approach, which is based on the Nextera technology from Illumina. Essentially, both of them are similar in many respects. They've got 3 to 4 instruments. The total instrument cost is around $150,000. Then they start to differentiate based on how much data they deliver, essentially. The simplified PCR approach is around $37 for the whole thing, from end-to-end sample all the way through to analysis, relative to around about $90 for the Nextera. Now, I say these as costs that are purely estimates based on list prices of things that are available. Since these systems haven't actually been put together yet, we're still in the middle of that. These are just estimates of sort of list price that we expect out of these things. From there, they start to differentiate, one being a more targeted, simplified approach where you just get what you need, and the other one gives you a little more information for a little more money and a little more time, essentially. So next steps for us is we're going to conduct comparative performance analyses of the automated DNA extraction systems. We're looking at about 5 systems to compare head-to-head, look at the performance, and basically determine which is best of class to fit into this integrated workflow. We're going to do the same thing with the available TB DST assays that we have, the 2 different assays, the PCR approach versus the NextER approach. And then we're basically, by mid of 17, we expect to have an integrated system put together, which we will then test out in a single supranational lab, determine where the flaws are, fix it up, get it ready for 218, and then basically by the end of 218, Q3 of 18, we expect to have finished a multi-site study of essentially a simplified, optimized NGS workflow for TB DST. And we hope to be able, if it all goes well, we hope to be able to present the data for CE-IVD marking by the end of 18, and hopefully also for WHO endorsement as a simplified system that can then be put into countries and funded by Global Fund. So that's the goal. Everything so far is on track. In terms of conclusions, we expect to have a validated end-to-end targeted amplicon NGS solution available for WHO endorsement by the end of 2018. This is a very simplified, mostly automated benchtop solution that looks, so far, the performance looks excellent, but we're going into the testing of that more now. Instrument costs about $150,000, so it's certainly not cheap, but it's comparable to some other technologies that are around right now. Reagents and consumables, probably less than $40 for an end-to-end solution per sample. That's very dependent on batching and workflow. And then finally, the time to result, we're looking about 1 to 2 days, depending how the assays turn out. And that's it. Thank you very much for your time, everyone. The folks from FIND, Rebecca Coleman is our lead technical person, David Dollinger, Claudia Denkinger, Bill Rodriguez, multiple private and public partners, and ReSec TB Consortium is working with us on the back-end analysis. Thank you very much, everyone.